Uh, Good morning. Thank you very much for agreeing to have a bit of a chat with me today. And for anybody watching who doesn't recognise Dr. Emmett, she is a haematologist, and I believe your personal interest is in pregnancy-related haematology. That's correct? Yeah. So whilst I feel like you could just talk to me about haematology and I would learn absolutely loads, I feel we should probably try and frame it so that I'll ask you a few questions, if that's okay with you, and then just try and keep us on track. Is that okay?
Correct.
Great.
Good idea to keep me on track.
Yes. So I sort of want to start with a confession that I really don't know much about haematology. I did pass my exams, I promise you, but haematology is an area that I don't know so much about. So don't feel that you can't dumb it down
When
for
I
me.
started haematology, I was working in ED in London, and my mate was doing haematology. And someone pulled out and they needed someone to fill in. And I said, great, I know nothing about haematology. Perfect, I'll come learn.
Yeah.
And that was it.
And you didn't return back to ED, which some days I can understand. So what I'd like to start by doing is maybe asking you a couple of questions about iron, because I think there's been some things recently that have stimulated me to want to learn more about it. And also we've spoken previously and you've told me how sometimes the iron deficiency leads you, when people are pregnant, to discovering particular hematological conditions. So see if we can explore that a little bit more. Now, in ED, we don't really test for iron studies because it takes a while to come back. We never know the results. And I was led to believe that some parts of the studies are altered with inflammation and when people are sick, and so they're maybe not that relevant or true. So I guess that leads me to ask you, so what are the basic tests that you would do to explore somebody who you might think has got iron deficiency?
So first you might get a clue on the full blood count, if they've got anemia, or if the MCV, so the measure of how big the red cells are, if that's reduced, that would be a clue that they may have iron deficiency. Also, they might have a rise in their platelet count, which could also be a clue that they've got iron deficiency, because that can happen with iron deficiency, blood loss, inflammation, or infection. So then you move on to your iron studies. Now, you don't have to have any of those changes to have pure iron deficiency, but on your iron studies, you get 4 parameters. The first is iron, and that's relatively useless because it's affected by the recent intake, so I don't really look at that number. And then you get the transferrin, or sometimes called the TIBC, the total iron binding capacity. So that's the protein that carries the iron around in the circulation. And then the next number is the transferrin saturation, and so that's how much iron is bound to that protein in the circulation. So when I'm explaining this to patients, I usually say that's a bit like the fridge compartment, that's the circulating available iron. And a transferrin saturation below 20% is a reduced number. And to answer your question around what happens when there's infection or inflammation, well, the liver pours out lots of transferrin, that protein to carry that iron around in the circulation when there's iron deficiency. So if you've got a raised transferrin, that's pointing you in the direction of it being iron deficiency as the change in your ferritin that you'll see later. So then the last parameter there on those full iron studies is the ferritin. And as you say, the ferritin is an acute phase reactant, so that'll go up with infection, inflammation, some malignancies, liver disease. But it's our best marker of iron stores. So when I explain this to patients, I say it's a bit like your freezer compartment. That's the stuff that's in your storage. So an iron deficiency picture will be a low ferritin, below 30, a low transferrin saturation, below 20%, and an elevated transferrin.
Right.
And if you've got a low transferrin, but the rest of the parameters look like iron deficiency, then that's actually showing you that this is probably inflammation.
Right, okay.
So when there's inflammation present, all those inflammatory, pro-inflammatory cytokines look very much like a bacterial infection, and I think that we've been amazingly developed to survive bacterial infections, because we can last longer than bacteria can, and they also depend on iron. So our body creates a functional iron deficiency by sequestrating the iron to not feed bacteria. But I think that pro-inflammatory cytokine message looks very similar to from bacterial infection. So we see what we call an anemia of chronic disease or an anemia of inflammation with that reduced transferrin and that functional iron deficiency in quite a few states, particularly in some cancers.
Oh, wow. See, I can see all these little light bulbs coming on in my brain where I'm starting to understand.
So the iron studies are so useful.
Yeah,
and
okay.
I don't just use them to see if there's iron deficiency.
Right, okay. Oh my God. So when I mean, you probably don't get to see lots of patients who are just iron deficient, but what sort of common ways do these patients present? What sort of things are we looking for?
So symptoms of iron deficiency. Many people can have quite a lot of symptomatology even in the absence of anemia, and I think that's been an important recognition as we've been able to treat it. So 65% of our iron goes to making red blood cells, and the other 35% is going to all the rest of our tissue for particularly if you remember back to biochemistry.
Not really.
So cellular ATP. So the energy that every cell makes to function is ATP. In order to make that, it uses usually glucose or route into glucose plus oxygen, and that electron transport chain that creates ATP has cytochromes that are iron dependent. They require iron molecules in that electron transport chain. So it makes so much sense that all our organs that are very ATP dependent, our hearts, our brains, very mitochondrial rich tissue, needs iron. And so when patients present with brain fog, palpitations, even anxiety, sometimes
and
that
obviously
is just
lethargy.
And lethargy,
because they can't make any. Yeah, okay. That makes
so
sense.
that common description of I wake up in the morning, I've had 8 hours sleep and I am exhausted.
Yeah.
And I think that's reflecting that cellular energy deficiency.
Okay. So when we look to replace iron, I know that you can take tablets and things like that, so oral, but also I've noticed that a lot of patients have intravenous infusions these days, and I don't know whether that's just been me being more aware of it or us using it more regularly. Is there a bioavailability thing that?
So you're 100% right that we're giving a lot more intravenous ions, and there's two main reasons for that. The one is being able to do it. So the ferric carboxymaltose, the Ferinject product, reduce the transfusion time down to 15 minutes as opposed to the 4 hours.
It used to be a long time,
so our polymaltose was 4 hours, or the rapid infusion an hour and a half, as well as a lot more adverse reactions, anaphylactoid type reactions with the older preparations. So the accessibility was less there. But more importantly than that, we are recognizing the need for iron replacement in a variety of situations. So there's the iron deficient group, but then there's also those who don't have a ferritin less than 30, but actually need higher iron requirements.
Right.
And those, so the renal physicians for a long time now have been giving IV iron to their dialysis patients, those with renal anemia, because they to support that renal anemia. The cardiologists, most of the cardiac societies now, the Americans, Europeans, Australians and New Zealand, are recommending for the cardiac failure patients that they sustain a ferritin more than 100 and a transferrin saturation more than 20%, because they've had some really interesting studies in those in the cardiac failure patients showing that they have reduced hospitalization, better exercise tolerance, performance, and all of that. So
I was not aware of that. That's really interesting.
So, and it makes sense again, because that tissue, the myocardium is, it never rests.
Yeah.
Its cellular energy production
Hopefully
must
it
be
doesn't
huge.
rest. Yeah.
Exactly.
When
That's
it
the
rests,
goal.
it rests for a long time. Yeah, okay.
So there's a much more it's been recognised that way more patients are needing iron.
And it would, correct me if I'm wrong, but it can take many months of oral replacement therapy to actually get people's levels up.
Yes.
Yeah,
So it depends on where they're coming from, but the postpartum studies showed it took 40 days to get to the same level with oral iron compared to intravenous iron. In the cardiac patients, the reports of similar durations of time. The thing is 3 to 6 months.
Yeah,
okay. But in some of our patients, like the cardiac failure patients, there's also the issue of absorption. So they've got gut edema and reduced absorption. So most of the studies in cardiac failure actually very few with oral iron, if any, because of that issue.
Yeah.
And then we've got the whole surgical population as well.
None of the patients at John Flynn, when they have surgery, they don't lose much blood at all, though.
No, we've got
just
phenomenal surgeons. That's true. But even fewer of them are now having blood transfusions post-operatively because we are correcting their iron pre-op. And it's the same targets as ferritin above 100, transferrin saturation greater than 20% that we're targeting, particularly before joint replacements. Because those elective surgeries, you've got the opportunity to do their iron studies and optimize things. And it makes a difference because transfusing someone post-surgery, there were some really interesting studies that are reasonably old now, but highlighting what we call transfusion-related immune modulation.
Right.
And so what that's all about is the impact that having a transfusion has on one's own immune system.
Oh, right.
So it reduces the recovery, reduces your healing. And there are even some amazing studies looking at graft tolerance, so like kidney transplants and improved tolerance of a transplanted kidney because of the immune suppression in the recipient.
If they haven't had blood transfusion.
If they get a blood transfusion.
Oh, right, okay.
So that would be a positive. But then also growth of cancers in those who are having lots of transfusions because of the suppression of the immune system. Now, why I say those are old studies is because we now have universal leukodepletion, which is filtering the blood within the processing lab and taking off the white cells. So there are not that many white cells in what we give our patients anymore.
We do that on all blood.
It's not as big an issue, but it's still one of the considerations. And then the other one is obviously the exposure to red cell antibodies, which we can talk about.
So when we're talking about infusions of iron, I know that, we don't really do it that much, but I know there's a few complications that we concern ourselves with, and we try and do it in a specialist area who's aware of those. But just for the ignoramus like myself, what are the reactions that you would consent people for with when they're having an iron transfusion? What were the main things that you could make sure you told people?
So the reason why we've centralised all our infusions at John Flynn, and many hospitals have done the same, to our oncology day unit, where our nurses are doing venous access for them, and really, got fabulous nurses in our day unit, and because the biggest concern was if the iron extravasates, if it goes into the tissue, it can stain the skin, it's irreversible. So you can do.
I know that tattoos are very popular on the Gold Coast, but probably
it's not the design that most women are going for.
Right.
And so you can, like tattoos, get them lasered, but it's not 100%. So it's quite an ordeal. So, and that's all about the cannula. She's got to have a good flowing vein and not put it in if it's at all dodgy. So that's the first thing. And, our day unit's giving so many iron infusions, and that's it's not. I inform people. I tell them why we're doing it like that, but really it hasn't been a problem. Then the second thing I tell them about is that in the next 2 to 3 days that they might have headaches, muscle aches, nausea. Again, that's really quite individual who has those sort of side effects. And it doesn't have to happen with every infusion. We've got quite a few patients, for example, those with persistent GI bleeds who need quite frequent iron infusions. So just because they have a reaction on one, it doesn't necessarily mean they're going to always have those side effects. One of the things that I've noticed is that it may be related again to that transferrin saturation.
Right.
So if they've got a high transferrin saturation, they might get more of those sort of inflammatory effects. So I really weigh up carefully when I'm giving it and what dose I'm giving.
Okay.
Because at the end of the day, as you've alluded to, there's usually an alternative. So you can take tablets.
Yeah. Okay. Yeah.
You
You can get. It's not necessarily an allergic reaction, but you can get anaphylactoid
anaphylactoid reactions.
Yeah, okay.
So they're incredibly rare.
Yeah.
But if they happen during the time of the infusion, switch off the infusion, give them fluids.
Yeah.
Head down.
The usual stuff.
Antihistamines.
Yeah.
Hydrocort.
Yeah.
And even that. To be honest, it often looks a little bit more vasovagal with.
Oh, okay.
That it's just
difficult to tell.
Yeah. Because they can get diaphoretic and drop their blood pressure.
Any other main
it's incredibly,
reactions?
honestly, it's like 1 or 2 a year of that.
Yeah, okay. I can relax then. Yeah, good.
And then the big thing that is important to know about is dropping the phosphate. So particularly the ferrocarboxymaltose, the Ferinject, more commonly than the other preparations can cause the phosphate to fall. It's about stimulation of FGF23.
Oh my god. Oh my god.
Anyway, the bottom line is that within a week to 2 weeks, the phosphate can fall.
Yeah.
And it's usually not too bad when it does happen, and that they might get some muscle aches. But it can persist. It can persist up to for sort of 12 weeks.
Right.
And rarely it can actually be quite a significant phosphate fall that requires replacement.
Yeah.
I've been telling people for about 2 years to have daily dairy, particularly cheese and yogurt, which usually goes on really well. Most of the time when I tell people that they can have cheese every day for a week.
Can you have red wine as well?
If it helps you eat your cheese.
Yeah, okay, it does actually, it does, yeah.
That really has actually reduced the rates of low phosphate. So that's the other thing we have to tell them about. And those are the key
main
things.
So,
staining the skin, those side effects in 2 to 3 days, phosphate and anaphylactoid reactions.
Okay, good. All right, now I think what we should do now, Shannon, is we've ended up talking about iron for quite some time. And so I think we'll call it a day there. There will be a part 2, and we'll come back and talk to you about some more hematology issues shortly.
Thank you.